I'm the new guy, so I've been in the Mount Vernon community for about a year. Prior to that, I was in Columbus. I still live in the New Albany area, but I worked in the Mount Carmel Health System for the past 13 years. And so now I'm up here, able to bring a different skill set, kind of expand on our skill set and everything. So robotic surgery is something that I'm really passionate about. We'll kind of get in what is robotic surgery, why robotic surgery. We've got kind of like a little template of what we're going to talk about today, but I love robotics. It's fascinating. And so it's kind of like I see everybody walking around. This is robotics for surgery. Okay, it's basically technology. We'll be going over what we used to do, what we can do, what we might be doing, and just kind of talk about surgery in general. All right, so as I mentioned, we're going to be talking about the development of robotic surgery, how it came about, why did we start robotics in the first place, current applications in the surgical realm, what does robotic surgery entail, who does it, who doesn't do it, what can we do, current technology, where we were, where we're going, and kind of where we're at with whatever iteration, iPhone or Android, Google, whatever you're at right now, similarly. What do we do here at KCH? What does our robotic surgery program look like? And of course, where we might be going in the future. First things first, am I okay to talk about robotic surgery? I think, obviously I'm biased, but my answer is yes. So I did my first robotic case in January of 2013, coming out of, I graduated as a resident in 2011, and I did not learn robotics in surgery. So as a general surgeon, we have to learn open surgery. As a general surgeon, we have to learn endoscopic surgery. So for those of you folks that have had colonoscopies or endoscopies, we have to learn how to use video cameras. And then of course we learn laparoscopic surgery. That's all standard from the American Board of Surgeon, the American College of Surgeon, and all of our governing agencies from a higher up academic level. Robotics is not. Robotics is something new. It's on the forefront. I won't get into the academic research about should surgery residents be learning robotics at all, but that's totally separate because believe it or not, even though we talk about robotics, it's been around for about at least 25 years, it's technically still not standard of care. And what I mean by that is not all hospital systems have a robot. Okay, and we'll get into what does that mean here in a second, okay? But I wanted to do robotic surgery coming out. We went through a phase of doing what's called single site surgeries, and we'll kind of get in that. That made a presence and then kind of went away. It might be coming back. But basically, we could do gallbladder surgery through a 2-inch incision through your belly button, and that was it, okay? And the robot helped us do that, and you'll see why here in a second. From a milestone perspective, as I was just telling Abigail here a second ago, so I actually did my 1,000th robot case here at KCH. So between 2013 to 2024, I've done 1,000 cases. That's not bad. So some people, 2,000, 3,000, 4,000 within a 10-year period, so they're cranking. Okay, that's a lot. I was, as I mentioned, at my previous position, the robotics curriculum director for the general surgery residency program through Mount Carmel Health System, teaching residents how to do robotic surgery. It's kind of like teaching toddlers how to walk and holding their hand all the time. So, but that's what we did. I was in the residency program. And then, of course, that's just a little pitch for me. If I can do something robotically, I prefer to do it robotically because there's benefit for me, but there's also benefit for the patient as well. And we'll get into those reasons here in a second. Development of robotics, okay, so as I mentioned a couple of lead questions here. What is the purpose of robotic technology? What were we doing as surgeons doing before robotic technology? Why aren't surgeons all still using those techniques in the past? Evolution of surgical techniques. Obviously surgery, I don't know if you guys know this, surgery was actually invented before anesthesia, believe it or not, okay? So surgery, and I'm not talking Civil War anesthesia, I'm talking about surgery in the modern era. It was probably in the late 1880s where we talked about doing surgeries for gallbladder disease, for appendicitis disease, and it was actually before anesthesia. So evolution of surgical techniques. Next is what is robotic surgery? What is a robot per se in standard terms? And then who does robotic surgery as well? So as we get into things, this is a little history lesson if you want to get into it, but robotic surgery is just a technology that allows me to do my job better. In the 70s, let's pick a Chevette. Chevette got you to work just fine. Robotic surgery now is a Lamborghini. That's the only difference. I'm still driving to work. I'm still doing surgery. I'm just doing a different technology. Everybody, well, most everybody knows how to use a rotary phone. Okay, those still work fine. Okay, but everybody's walking around with a phone in their pocket. It's just an advancement of technology, okay? So it's still surgery, but it's technically just a technology. So if we want to get into the definition of a robot, here's some literature based on word robota came from over some Eastern European literature. And robotics actually came from Isaac Asimov, okay? So if you go back into the literature, he actually used it in one of his publications in 1941, and he said, okay, well, if the design of electrical devices is called electronics, well, maybe the design of robots should hence be robotics. So that's where it came from. Other things, just from a historical standpoint, some weird miniature statues and androids and everything, we can trace that back as far as the 7th century BC. This is in the Iliad, where we can make handmaidens out of gold. They can actually trace back a mechanical pigeon to 400 BC as well. But that's obviously a far stretch of what we now consider what a robot is to be. But as we all know, robots, we don't want to say robots are taking over our jobs, but robots, it's an advancement in technology. So robotics currently is used in industrial, military, exploration, homemaking, academic, as well as research applications. So robot, again, is just another technology that people are doing to do their jobs easier, better, or unfortunately replacing humans altogether. So now we're going to go over, okay, where were we and where are we going to go to? So open surgery is good old-fashioned surgery, okay? One of my old mentors used to say, don't let skin get between you and your diagnosis, okay? So big surgery, open surgery. This is actually a cardiac surgery. This is a retractor. So this is a cracked open chest. So that's somebody undergoing some sort of heart surgery. But surgery in the open day used to be a big incision from an abdominal standpoint, from belly button up, belly button down, or your pubic bone up to your xiphoid process, and literally what's going on in your abdominal surgery or abdominal cavity. We can see everything, we can touch everything. So that's classic open surgery. And then we started getting into laparoscopic surgery in the mid to late 80s, usually the early 90s, where now we're starting to use scopes and cameras. And we're still operating on the patient down here, but as you notice, some of our instrumentation is going in through the abdominal cavity, and we're watching everything on video. Okay, so now I'm kind of playing video games. But as we'll get into here in a second, the surgeon still has the instruments are still going into the body is still touching these instruments. I have what's called haptic feedback. I can grab tissue, I can pull tissue, I can manipulate tissue, but I'm doing the surgery on a TV screen with what's going on in you, so to speak. Now, this is obviously a lot better than having a big, 2-foot incision on your belly. You go home quicker, decrease pain, increase recovery, decrease morbidity. We'll get into some of those things, but this is where laparoscopic surgery kind of came into play. Now we're doing what's called robotic surgery, or generation 3. And when we talk about robotic surgery, usually we credit Da Vinci, and that's from Intuitive. So Intuitive is like Ford Motor Company, and Da Vinci is the Chevy Buick, or Ford, Fairlane or whatever. So unfortunately, there's only one game in town, and that's the Da Vinci robot. So they've been around for at least 20, 25 years. You can't get a Chevy, you can't get a Ford, you can't get a Mercedes, it's just a Da Vinci. Okay, they're the only robot in the general surgery world for the abdominal cavity. They were first to the technology, and they have exploded as far as what they can and can't do. But if you're going to go get a car from a general surgery standpoint, there's only one car out there to get, and he's really expensive. Okay, so the latest generation of robot that we have here at KCH was around $2 million. Okay, so it's a very expensive technology. But we'll get into why this is better here in a second. So a little bit of history with some robotic surgery or technology. Way back in 1985, actually, they started doing stereotactic brain biopsies because it sat on a carousel. You can input coordinates, and you can actually have a brain biopsy that way with this computer system. Okay, it just improved accuracy, and surgeons obviously have good hands, at least I think we do, but there's still some tremor, there's still some manipulation or movement there, and so they were thinking that by computerizing some of what we can do, it stabilized, maybe decreased errors, and decreased harm to the patient. And then in 1988, this other thing called the Probot, or the prostatectomy robot, and for the guys in the room, I don't think any of us want this where sun don't shine, but that was actually a biopsy machine. That is actually a biopsy machine for a prostate, okay? And so again, it stabilized everything for a more accurate biopsy, okay? Orthopedics, our orthopedics colleagues have robots as well. They started in the early 90s. We do have an orthopedic robot machine here. It's basically for stabilizations of bones and everything. And this basically stabilizes the hip so the surgeon can kind of make his cuts, his or her cuts, and do surgery on the bone stuff. So when I'm talking about robotics today, I'm a general surgeon. I operate in the abdominal cavity. Okay, I also do breast, thyroid, skin lumps, and bumps. But traditionally, now, when we're talking about robotic surgery for today's discussion, it's all in the abdomen. Okay, and we'll get into what we can and can't do here soon. Modernized the technology a little bit. So this Zeus robotic surgical system, and then, as I mentioned, the Da Vinci surgical system. So Intuitive actually bought Zeus, and so this is what we consider the modern day of robotic surgery, which is the Intuitive surgery platform here. And as if you guys can already see, I get to sit down, okay? And the patient's over here, and so I have a bunch of helpers, surgical scrubs, nurses, assistants, and everything like that. And I get to sit in this big fancy machine here, and we'll get into why that's kind of cool here in a second. But one, I hope to have a career for 30, 35 years. And if I have to stand up like this for 35 years, there's actually data out there for surgical ergonomics, okay? Back problems, neck problems, hunched over, my radiology or my interventional radiology colleagues that have to wear lead all day long and do heart caths and injections and everything. There's data that they get shorter as their career goes on because they wear lead all day long. Okay, so anything that makes my job easier, I'm good for it. Okay, other thing, NASA, military applications for robotic surgery as well. So robots were developed mainly in the medical field. Researchers began this concept called telepresence surgery. And so when we get down here to our military, basically if our troops are doing whatever it is they're doing, and I'm the surgeon and I need to fix them, it's kind of, nobody wants to get injured, but if I'm trying to fix people that have gotten injured in battle, we want to make sure we can get to them, but I might be in a different physical space than that troop who I am operating on. Okay, and so that's called telepresence surgery. So the surgery is taking place somewhere else that the surgeon is not. And I'll show you that actually happened. Okay, and so that's where this technology also comes about, because as I showed you in the previous pictures, the surgeon's on the console and the patient is somewhere else. So let's go through a couple of things that were kind of milestones in the surgical realm. So this is Dr. Falcone at the Cleveland Clinic, and then July 1997, he had the first robotic, by the way, this is all robotic milestones, the first fallopian tube reconstruction. So after a tubal ligation, he did a robotic surgery, sewed the fallopian tubes back together, and that female actually got pregnant afterwards, okay? Now, why did they get a tubal in the first place? That's not the point of this discussion, but ended up reconstructing everything with a successful pregnancy. And then in Germany, first robotic-assisted heart bypass. So, you know, that big incision that I showed at the beginning of the talk, little teeny tiny incisions on the chest, robot goes in and actually was successfully able to do a bypass surgery over in Germany. And again, that's in the late 1990s, so that's, you know, almost 30 years ago, okay? And then at the Ohio State University, so heart bypass actually happened as well. And so that was big. Ohio State, as well as major academic centers, have a very robust robotic surgery program, but this was a really big milestone. Okay, and then this one was the cool one from a telepresence surgery, aptly named the Lindbergh operation. So for history buffs, we already should know what we're going with this. So there was actually an American surgeon and a French surgeon that they did a gallbladder surgery from New York on a patient in France. Okay, and so that was 20 years ago. Okay, so a long time. So that's why it's called it. So that was kind of cool. So that telepresence, meaning can we adapt this technology where surgeons are not, but patients are? And you can actually kind of like dial in and do a surgery. Okay, so when anything that we do in surgery, obviously scrutinized from a government standpoint, scrutinized from an industry standpoint, but more importantly, scrutinized by our colleagues. Okay, so if you're doing something a little off the ranch, a lot of people are going to start looking at you going, should you be doing this or not? Okay, even though the technology is there, should we, could we, use that technology. So even and I put this in this from a surgical standpoint, this is the New England Journal of Medicine, by the way. So one of the medical publications from a peer-reviewed standpoint, by the way. So surgeons must progress beyond the traditional techniques of just cutting and sewing to a future in which minimal access to the abdominal cavity is only the beginning. So 20 years ago, we're scrutinizing ourselves and going, okay, this is here, this is real, should we be doing it? How are we going to be doing it? Who's going to regulate it? And what applications can we use with the technology? Okay? So a little bit of history, we'll go back to laparoscopic surgery. So remember, open, big incisions, laparoscopic, little teeny tiny poke holes, blow your tummy up with there, put the video camera in there and do everything on the TV. So this kind of started in the mid-'80s, and this was a German surgeon that he did, quote unquote, the first laparoscopic gallbladder. And so this is actually from his reasoning on why he did it. And believe it or not, the first laparoscopic appendectomy that was performed was by a gynecologist. And so as a general surgeon, he was like, whoa, 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 whoa. Well, this is, we need to start taking some of this stuff back, and we need to step forward and take control of our own field. So even an endoscopic appendectomy was discussed. I was convinced that if we, meaning the general surgery community, passed up laparoscopic surgery, that our internal medicine colleagues and our gynecology colleagues would again take away a piece of our competence. So there was that drive or that desire for general surgeons to lead in the forefront. Okay? And so in his initial series, he had 94 patients. 6 of them were done in the traditional laparoscopic way. And then the remaining 88, he had pneumo, means pneumoperitoneum, where we blow the tummy up with air. We put the gas in there so it creates like this big, you look like a huge hippopotamus. So we have a working area, okay? And so he had optical guidance. He had a couple other things. Single incision preference. He thought it could be done more quickly rather than 3 to 4 incisions. We'll get into that in a second. He felt that it was going to be more attractive to general surgeons and more readily accepted by the surgical community, what he was doing, by the way, in the 80s. And so he actually did it, and he presented all of his stuff at the Congress of the German Surgical Society in April '86, and he was a laughingstock. He was laughed out of that meeting, and this is what he was criticized as. He was described as performing Mickey Mouse surgery, small brain, small incision. He was laughed out of that conference for doing something different. Well, they kind of stuck to it, and then, oh wait, other people started doing what he did, and they're geniuses, okay? So in 1990 at the SAGES conference, and SAGES is a big conference for us, so that's the Society of American Gastroenterologic Surgeons, so GI doctors and GI surgeons, all of these other people, after Mew, got credit for it, and he did not, even though he presented, okay? And so there's a big kind of back and forth and a hullabaloo to kind of see what was going on. And so in 1992, finally, Mew got recognized from the German Surgical Society for having an award. And then finally, 9 years after these guys were recognized, even though he was 5 years before them. So getting this technology up and running and more accept took a little bit of uphill work, okay? So he was finally recognized by one of our big societies as performing the first laparoscopic surgery. So early laparoscopic surgery was interesting because open surgery was the standard of care. I've got a big problem in my belly, you need a big incision to take care of it. And now we're thinking opposite of that. We're thinking smaller. How small can we go, but still take care of that big operation? So it was a little bit backwards. So surgeons, just like a lot of people, we don't like change. We don't like people telling us how to do things. I went to school, I did residency, this is how I'm comfortable with. Why do I need to learn how to do it differently? Okay, so there was some resistance, okay? So there was little interest in wasting time changing the surgical management of an operation with a mortality rate as low as that of chole. Now we keep going back to cholecystectomy, a gallbladder, because I don't want to say this not esoterically, but dismissively. Gallbladder surgery for a general surgeon is pretty bread and butter for us, right? So gallbladders and appendix, that's like anybody should know how to do a gallbladder and appendix. So a general surgeon, so we use this as our walking modality. You got to learn to walk before you learn to run, okay? So if you want to learn how to do advanced minimally invasive surgery, you need to know how to do basic, minimally invasive surgery. So for us in the general surgery realm, a gallbladder surgery is considered a basic operation. But again, I'm not belittling it. It's still a surgery. It's still general anesthesia. But anybody should be able to do this. So this is what we compare a lot of things to. And so initially, everybody's like, oh, I know it's a gallbladder surgery, but hey, is it safe? Is it not safe? Okay, so a lot of people, and this was published, by the way, so laparoscopic surgery was described as a futureless technique. Circus surgery, remember Mickey Mouse surgery in the 80s, with a mediatized show of a tightrope dancer totally careless of the risk for patients. That's how it was described. Okay, now it's standard of care, by the way. Okay, so it was very, very heavily scrutinized. And so early laparoscopic surgery did demonstrate a cost advantage over a big incision. Go way, 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 way back. So in the early 1900s, if somebody had appendicitis, they'd be in the hospital 10 to 14 days. Now, I do your appendicitis surgery, you go home from the recovery room. Okay, so that's a cost. Okay. Also, there is a significant learning curve because you need to learn, so we're not operating with our hands, I'm operating with my hands on an instrument through a fulcrum into a body. You gotta learn how to do that. So there is a curve to that, but it is safe and effective procedure with minimal risk, and just like anything, the more you do, the better at it you're gonna get, okay? Laparoscopic surgery, and again, this is early laparoscopic surgery. Can gallbladder surgery be performed by surgeons who are only trained in biliary surgery with meticulous technique? And I'm going to show you a couple of slides of where that was published. So laparoscopic surgery, again, is still being scrutinized in the early 90s. But they did say that laparoscopic surgery seems, may not be universally applicable to the entire spectrum of gallbladder disease, but it can be performed as a safe, standard gallbladder surgery as long as the patients are selected properly and appropriately and cautions are exercised. This means I think we can do it in the best patient under most awesome circumstances, and they're not sick, and we have everything at our ready, and everything's perfect, perfect, perfect. Okay, so, and only it was recommended to be done in advanced hepatobiliary centers. Ohio State, Chicago, Boston, huge academic centers, okay? And so, the Ohio State actually did some studies in the 90s, and I say this, watch out, it's a lap chole, because I stole this slide when I used to teach my, my residents, so my residents can do a gallbladder, by the way. But they looked at this, and they said, okay, laparoscopic surgery's here, how do we do it? Can we do it, okay? So they took 100 patients with symptomatic biliary disease and 4 with acute cholecystitis. Now what's the difference? Symptomatic biliary disease is, I have gallstones, I eat, I feel like crap. So I'm not gonna eat like that because I don't wanna feel like crap. You have gallstones. Acute cholecystitis, like tonsillitis, appendicitis, is an infection of the gallbladder. So it's where one of your gallstones gets stuck, nothing can get in and out of your gallbladder, and you get an infection. Fevers, chills, nausea, vomiting, night sweats, sick, emergency room. Step up of less than ideal conditions. So we've got 100 patients, but they were only like, no. We're only going to do this in 4 sick patients, okay? In their first month, their OR time was 2 hours, plus or minus 45 minutes. But they demonstrated it in their last month, and I forget, unfortunately, how long their initial, their 100 patients was. I think it was like 9 months. In their last month, they at least got it down to just a little above an hour. Okay, so obviously here's the learning curve, but it's doable, okay? And then this is what they said in their studies is, can this technique be applied for acute cholecystitis? Remember, they only had 4 patients that were sick, okay? And then can this procedure be performed safely by the average general surgeon in a community or a rural setting? Could laparoscopic surgery be performed here at KCH? And in the early 90s, the answer was, nope. Okay, so this is academic universities going, how applicable is this across the spectrum? Okay, selective versus routine cholangiography, we're not gonna worry about that. That's kind of putting dye in the biliary system so we can identify anatomy. So will lap chole afford a means of decreasing morbidity and mortality in high-risk groups requiring elective cholecystectomy? Means, can we step it up a notch and go, okay, I don't just have 25-year-old females with perfect anatomy who aren't sick coming in for symptomatic biliary disease, but can I do it in somebody who's 72 and sick and has a fever and infection, and will we be able to attain the same results? Okay, so basically they said it is clear that lap chole is a useful procedure it has significant, although perhaps not dramatic advantages over an open chole. Now, if you know anybody with an open chole, that's an incision up underneath their right rib cage. It's about 6 to 12 inches, depending on how big your body habitus is, okay? Still good surgery. We can still do open surgery, by the way, but this is what we are comparing it against. It can be performed safely by experienced surgeons, again, in properly selected patients, and represents a significant and permanent advance in the management of biliary tract disease. So in the early 90s, they finally said, okay, we can do this. Now let's see who else we can do it for. And that was just for gallbladder, by the way, okay? So 30 years ago, a laparoscopic gallbladder surgery was considered to be a highly skilled procedure to be performed only by experienced hepatobiliary surgeons in academic centers, offered only to the most ideal patients, and had strong reservations of dissemination of the technology to the routine general surgeon. You had to go to the city to get this done. And now it's standard of care everywhere. And that's in 30 years, okay? So laparoscopic surgery was great. It was scrutinized, but now that we've been doing it for about 30 years, we've noticed some disadvantages of it, okay? So first thing, two-dimensional view. I'm literally watching the TV, okay? So when I'm doing an open surgery, we're human beings with two eyeballs. Everything's stereoscopic, right? So you can get in there and move. I have depth perception. I know if I'm sewing on something, if it's here or there or right or left. That's all gone with laparoscopic surgery, right? Because you're just watching a TV. Okay, so reverse movement. This one's a big one, okay? So there's a fulcrum in your body. So if I want to grab something through a fulcrum and move it up, what's my elbow doing? It's moving down. Okay, so in open surgery, I pick it up and it pulls it up. If I want to move it up laparoscopically, I have to push down. Okay, so there's an inverse of movement, okay? Fixed instruments with 4 degrees of freedom. That's it. These are straight sticks. My hands and arms are not straight sticks, okay? In, out, up, down, left, right, and rotate. That's the only thing you can do with a laparoscopic instrument. Still works great, still little teeny tiny poke holes, but now I am not as capable of grabbing something, moving it, and reaching around, okay? It's just in, out, up, down, left, right, and rotate. Possible misalignment of hands and instruments all day long. Okay, if you're not used to this, you're going to run into yourself, okay? Increased sensitivity to hand movement. This is why Sam comes in. Sam's our medical student on rotation with us right now, okay? So usually during laparoscopic surgery, medical student, you're up to bat. You get to hold the camera. This all day long. I get nauseated, okay? And so it's tremor. So nerves, whatever, okay? But even if anybody holds the camera, the slight twitch of a hand movement gets transmitted through the camera, through the shaft in the abdominal cavity, and the screen shakes, okay? Because it's a video, okay? Can happen, doesn't happen. Sam's good. She doesn't do that, okay? Okay. And then inability to accurately identify disease or anatomy. This is because it's 2D. I can see a gallbladder, I can see a liver, I can see your bowel, I can see your stomach, but if I'm working on those things and I'm like, okay, is this behind or in front? So it's kind of, you guys ever been to the eye doctors and they have the stereoscopic images on the wall where you have to like stare at it and let your, like don't think and your eyes just, and there's like a horse or like a ranch or some kangaroos or something. Your eyes have to fixate from a three-dimensional standpoint. That's lost in laparoscopic surgery. We're just watching TV, okay? So that's lost, okay? So now let's move into robotic surgery. So robotic surgery, in addition to the telepresence and everything like that, is pretty cool because it was also developed to overcome the shortcomings of laparoscopic surgery, okay? So motion scaling and tremor-free movements. I've got this nice big machine that's not a medical student holding that camera in position all day long. Not gonna move until I tell it to move, okay? Also, I don't know if we can see it here, but it's got 1, 2, eyes, and there's another arm over here. I only have 2 arms. The robot's got 3. So I can be my own assistant doing the surgery, okay? Which is weird because you got to learn how to be an octopus, okay? Articulating instruments with greater degrees of freedom. So rather than those straight sticks, I can, and it's also not reverse movement because even though we're still in the abdominal cavity with a fulcrum, you hit a button on the computer, Up is up. Down is down. Okay? There's no more of this. Now the instrument is doing this, but on the console, I'm moving my hands up. That robotic hand on the inside of the patient is also moving up. And I can rotate my hands and I can flex my wrists. So I can literally grab something on the inside and completely turn it over like you're picking up an apple. Okay? And so we're going to see some of that stuff here shortly. Okay? And so that was really nice. There's also scaling. Also, three-dimensional imaging. This is a game changer. When I put my head in that thing, it's in 3D because there's two eyeballs. There's two on the camera lens. By the way, the camera lens itself is about $150,000. Okay? There's two different cameras. So movies now sometimes are filmed three-dimensionally. Two cameras right by each other. So this three-dimensional camera is transmitted to this headset. And I get to do your minimally invasive surgery in 3D like I would have done from an open surgery, but with the benefits of having the little teeny tiny poke holes. Okay, so that's different. And I get to sit down and save my back. I'm getting old, okay? So the potential advantages that robotic surgery are for me, from my perspective, again, immersive view through small incisions. Today's incisions are only about 8 millimeters in size, okay? 8 millimeters in size. We can go up to different things depending on the instruments that we need to put in. There's 8, 10, 12, 15, and that's the biggest one, okay? So depending on what type of instruments we need to put in and out, but 8 millimeters is most, okay? Now the problem is that if you've got a big honking sick nasty gallbladder, it's probably bigger than 8 millimeters, by the way, okay? So I can't deliver a 10-pound baby through a 2-pound hole, okay? So sometimes we need to do that, but small incisions. Overcome limitations of the human wrist. As I mentioned, actually I can take the robotic instrument, rotate it a full 360 degrees, take my hand off the control, grab it again, and rotate it another 180. Okay, so I've got that much rotation from an instrumentation standpoint. And again, it's wristed and articulated as well, not just in and out. Cameras, Sam and I were just talking about this today. Reach inaccessible areas. I can zoom, and it looks like I'm doing surgery right here on the inside of you because my hands are in there as well and my eyes are right there as well. And so we can literally sew on common bile ducts that are 3 millimeters in size. Robotic prostatectomies for gentlemen can be done in urethras are sewn that are anywhere from 2 to 5 millimeters in size. Okay, and so actually we have sutures that are that small to be able to accommodate that as well. So we can work in very, very tight spaces. Improved ergonomics over laparoscopy. Remember, I don't have to stand bedside and get nauseated when Sam shakes all the cameras. And then I can operate while seated. Now, I start the surgery. Robotic surgeons start the surgery. We get everything set up. What we do is we dock the robot. Okay, and I'll show you that here in a second. It comes over the patient. We hook up everything, and then I break scrub, and then I go sit down. I do the operation, and then depending on who I have in the operating room with me, either they take it all off when I'm done with the surgery, and they sew your incisions closed, or I scrub back in to close your incisions, okay? But it allows me, some of our surgeries, I had an old partner that did what are called robotic Whipples. Okay, a Whipple, unfortunately, it's one of the largest general surgery operations we do. It can be anywhere from 3 to 6 hours. Big incision. It's for pancreatic head cancer or first part of your small intestine cancer, duodenal cancer. And it's a pretty invasive procedure. Surgeons can do that robotically now as well through 4 little teeny tiny poke holes. Okay, and we resect half of your stomach, half of your pancreas, and half of your biliary system, and we put it all back together. Okay. Reduced fatigue, obviously if I'm in a 3-hour surgery and you're 400 pounds and I'm trying to operate on you, I get tired, okay? And so I don't have to do that anymore, okay? The robot literally does all the heavy lifting, okay? Minimally invasive approach remains possible for obese patients. Again, we don't necessarily do it here. Dr. McLaughlin is getting there, but for gastric bypass patients, okay, so for our weight loss program, robotic bypass, she does laparoscopic bypass, that's what she's comfortable with. She's getting into robotic weight management procedures as well, okay? Advantages to you as the patient. Still being done in a minimally invasive fashion. It's still minimal access surgery with the 8mm incisions. Decreased pain. Here's the fulcrum advantage. So during laparoscopic surgery, even though that fulcrum is in your body where the instruments go in and out, it's not fixed in space. So it is fixed in your abdominal wall, but if I'm torquing on you to do those instrumentations, your body wall's moving with it, unfortunately. And unfortunately, when we do bypass procedures, I've seen bent instruments and bent cameras, okay? Our OR administration gets mad when we do that, but it happens, okay? The fulcrum advantage is that robot holds onto that camera in virtual space. It does not move left, right, up, or down. It is there and literally rotates on a virtual spot. And so you have less trauma on your abdominal wall when you have a robotic surgery. So that incites a faster recovery, shorter hospital stay. Obviously, we know that it's safe, accurate, and precise, and reducing complications, readmissions, and time to recovery while increasing patient satisfaction. So if you feel better after the operation, you're going to say, hey, this is great, right? And so when I do robotic inguinal hernia repairs on guys who have had an open inguinal hernia repair 20 years ago, they usually say, oh man, I wish this was around 20 years ago. I remember just sitting around and having an incision down in my groin and everything, and you did all of that with 3 little guys like this. This was remarkable. So there is a patient advantage, okay? This is just some data from old slides that I've taken, obviously 2008, but this was the growth. Remember, robotic surgery really didn't take off, even though the technology was there about 99. It was still in its development phase, so between 99, 2000, even to 2005. Okay, but this is again, worldwide growth, international growth that we see, so United States, and these are procedures. Now again, we'll get into what, this isn't just gallbladders, by the way, this isn't just inguinal hernias, this is all procedures, but we can obviously see where we went from just barely over, bless you, over 100,000 procedures in 2008 to over 500,000 just 5 years later. Okay, so it skyrocketed, okay? Other data, so again, this is Da Vinci data. This is the only Ford on the market. So this is when we received FDA clearance of Da Vinci surgery for prostatectomy was actually in 2001. And so we used to do, and again, I'm not a urologist, but if for the guys out there, so if you need a prostate surgery, that's done by a urologist, okay? It used to be percentage of all procedures. This is open and laparoscopic. Laparoscopic prostatectomy is really difficult because you got to get down and sew, I told you, on a 3 to 5 millimeter urethra. But most of the prostatectomies were done open. Look what happened. Okay, and that's just in 5 to 7 years. So, and I will go so far as to say this, that if a gentleman needs to go have a prostatectomy, it needs to be done robotically. And that's not just because I'm biased, but there's a lot of stuff that was complications and side effects from an open prostatectomy. So I don't have the data on that. Again, I'm not a urologist, but I would say that almost a lot, I would say probably at least 80 to 90% of all prostate surgery done, I would say go far as to say worldwide is done robotically now, okay? Not to say this rudely, but if I were to go see a urologist and he or she said, I'm gonna do an open prostatectomy, I'm walking out the door, okay? Because of the complications and everything that had traditionally been involved with open cases. Gynecology, okay? Now this is benign gyne, by the way, so there's like hysterectomies, and then there's cancer in the gynecologic world. Okay, so this is benign gyne, but again, that kind of took around 2005. This is for hysterectomies, okay? So there's laparoscopic hysterectomies, vaginal hysterectomies, and then open hysterectomies. So the gynecologist had a couple of different techniques. Interestingly, we note that laparoscopic kind of goes up, but we did notice that the vaginal hysterectomies go down, and definitely open hysterectomies went way, way down as well. So I don't know all of the details on this, but laparoscopic surgery for the gynecologist, they kind of went hand in hand. So they're like, oh, I can do it either or. It also depended on what institution they were at, because again, robotics expensive. Not all hospitals had the gumption to say, hey, we're going to try something new for $2 million. So it got there. But just to show market trend, okay? All right, so this is what we're talking about when we talk about doing robotic surgery. So surgeon, me, is over here on the console. Everything's fiber optic all over the place. This is what we call the vision cart. Everybody else is watching this, but what's the downfall of this? It's a TV screen. It's 2-dimensional. They can't see what I'm seeing over here in 3 dimension. This is the patient. This is, I forget what version this is. This looks like an X, but it's the robot. It's stationary. This is a 3-arm, 1, 2, 3. They make it 4-arm. Here at KCH, we have a 4-arm, okay? But here, this is what we were talking about earlier. High definition, so here's the stereoscopic vision on that $150,000 camera. It is controlled all by me. My assistants, who I greatly appreciate, don't do anything except put an instrument in and take an instrument out. That's it. The entire procedure is controlled by me. Where I look, how I sew, everything. If I can't see, it's my fault. In laparoscopic surgery, if I couldn't see, it was Sam's fault. Okay, but not anymore. Okay, and the cool thing is you can zoom. This is a digital zoom. Okay, so and you can motion scale as well. So you can sew laparoscopically. It's really hard, but again, everything I do on my wrist is transmitted through my instrument, through that fulcrum, into the tip of where my instrument's at. You can scale everything down into 3-to-1 motion, up to 3-to-1, okay? So I can actually scale my movement down, okay, to not go so fast, okay? Tremor filtration, obviously, mimics the surgeon's own hands. So if I want to grab something, I grab it and I move it. I want to look behind something, I grab it. I actually physically look at the camera and I move it, okay? You can't do that laparoscopically. Intuitive motion, this is where basically when we were doing the single site, right is left, left is right, there was a weird fulcrum. We don't usually do this anymore. This was an old slide from one of the earlier versions of that guy, okay? This is a big list of what we can do robotically, okay? So I focus here and as well as here, okay? But basically, we can do lots of stuff robotically, okay? And that's in all cities. Now remember, in the 90s, everybody was like, whoa, 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 wait, laparoscopic surgery? I don't know. Now look what we're doing robotically. Okay, many people are doing robotic surgery for anything and everything that we can theoretically do. What's not on this slide right here is interesting. This is most international stuff, but what's not over here is in some cultures, Indian, Middle Eastern, Asian cultures, incisions on certain part of the body are frowned upon. They're scrutinized. So there are actually some societies out there, and I forget which one, I think in India a lot, you can do a transaxillary thyroidectomy. Okay? So all of the robotic instruments go in through your armpit, and they can take out your thyroid through your armpit. Okay? And so that's a cultural thing. We don't do that in the United States. In the United States, we're like, really? But it's a cultural thing. So remember, this is a worldwide technology. Okay? So gallbladders, anti-reflux procedures, this is an esophageal procedure. If you have stomach cancer, there's that Whipple procedure, pancreas surgery, spleen surgery. Believe it or not, my first surgery here was a spleen. I about exploded everybody's heads when I said I was going to do a spleen surgery here. Okay, but that was my first surgery here. Cardiothoracic, obviously bypasses, valve repairs as well. Our thoracic colleagues, if you know anybody that has had lung cancer, the cardiothoracic surgeon may have done their lung cancer resection robotically as well. Any types of hernias, belly wall, in the groin or up around the stomach, anything cancerous or diverticular related. So we can do anything on the colon, a total colectomy. Laparoscopically, we can do 4 little poke holes and basically pull out a 6-foot snake. Okay. LAR and APR are different types of colon surgeries. Appendectomy for appendicitis, of course. Bariatric surgery, as I mentioned, as well. Sleeve or other types of restrictive procedures. Here's gynecology and gynecology oncology procedures, hysterectomy, sacrocolpopexy, myomectomy, which is for fibroids. Our oncology colleagues really can get in the pelvis and do lymph node dissections in the deep pelvis along what we call the iliac chain, okay, where our blood vessels come out of our hips here area, so our pelvis get in really deep. Head and neck, this one's really weird, by the way. Transoral tongue resection. You're asleep. There's an instrument that goes in your mouth robotically, and they can do posterior pharynx, tongue cancers and everything, radical tonsillectomies. So they can do some crazy stuff even in the oropharynx as well. Urology, as I mentioned, prostate, and then partial nephrectomies too. Okay, so lots and lots of stuff. So this is where we're at in KCH. So this is me. This is our robot room. This is room 2. Here's some of it says me. So this was my 1,000th case last fall. So these are everybody helped. It's kind of momentous because it's a big milestone. But this is what we have set up. So our cart, so our vision thing is actually back there. There's my chair. So we course, is in the corner. So we sit in the corner. The patient is where all of these people are standing, and then the robot comes out. And in this version, this boom, as you notice, 1, 2, behind Brian is 3, and that's number 4. So we've got 4 hands, so to speak. 1 for the camera, and I've got 3 arms if I need it. Now, not all surgeries require 3 arms, but I can use 3 arms, so I can assist myself. This boom acts though the cart goes back and forth, and this swivel right here literally rotates, whether or not I'm working on the upper part of your body, or it rotates so I can work on the bottom part of your body. Now, one thing we don't have, keep track of this, we don't have here at KCH is called a motion table bed. It's really expensive. It's about $150,000, by the way. So the bed will integrate with the robot. So if I can't see anything, I usually say, hey, we need to move the patient a little bit and adjust their position. If the robot is docked to you, I can't move the bed. It's fixed. There's a technology where the bed communicates with the robot and will computer align the bed with where you want to move the robot and the bed at the same time and not hurt you. Okay? We need that. Yeah, we need that. Okay? Yeah, it's drop in the bucket. Okay? So our KCH program here, so we've only had this version. This is the XI. This would be like the iPhone 13. Okay, iPhone 12. Okay, so it's not, so that's when that came out. But thankfully, these things don't come out every year like the iPhone does. Okay, these will last for about 5 to 10 years, and then usually a new iteration comes out. So over the last 4.5 years, KCH has done over 1,300 procedures. A majority of those have been general surgery. Okay, so we have 4 general surgery. I'm one of them. Previous general surgeons did some of them did not. But most we do gallbladder, appendix, any type of hernias. As we get a little more advanced, we can do colon, foregut surgeries like spleen, adrenal, pancreas, and everything. And then Dr. Evans, who's one of our newest urologists, also does robotic prostatectomies here. Surgery started off, as we mentioned, big problems, big incisions. Now we're going big problems, how small can we go? Because the smaller the incision, from a safety standpoint, the quicker you as the patient recover. Okay, it takes a long time for somebody to recover from a big laparotomy incision. Can we fix you in smaller detail? So we went from open surgery, this is a uterus by the way, okay, this is a colon flopping out of here, to laparoscopic surgery, to robotic surgery in the traditional sense, and now, okay, there's this technology coming off as robotic single-site surgery. We did this for a while. This was kind of a flash in the pan, but it had some problems, but this also curved, a little bit goofy. It might be coming back though, because we can do surgeries just through your belly button. And the belly button is great from a surgical perspective because it is your body's only natural scar. Okay? Everybody's got a belly button. If you find somebody without a belly button, you let me know who they are, okay? Everybody's got a belly button, okay? So this is just some market stuff too. The robot on the opposite side of things has been scrutinized for a couple of different reasons. One is cost. It's an expensive machine, okay? It is a technology. Our iPhone, I think, what's the cost of our iPhone now? $1,500, but we pay for it on a monthly basis. The iPhone 15 is $1,200 to $1,500 for a phone, okay? So technology is expensive. Also, it was scrutinized as a marketing ploy. Come here, we've got the robot. Come here, we do awesome surgery. Well, unfortunately, people do read that stuff. You can go on your phone right now and go, I want a robotic gallbladder surgery, who's available in the next 75 miles? And they'll geofence you. And if you don't know what that means your phone's tracking you, okay? And so they can look at what's going on, okay? So this is kind of the progress of robotic surgery and opportunities. I have a lot of cool data. I just showed Abigail before I walked in. All of my robotic surgeries I can pull up an app on my phone, okay? I'm asking for my face, by the way, sorry. So I can go in, I can see, let's see, where are we at? Sam and I, we did our surgery on Monday, and I'm up to 1,065. I can pull up any one of those 1,000 cases. I can generate my own data. I can look at my own OR times. I can compare myself against the United States. I can compare myself against myself. How good am I getting at my gallbladder surgeries? Can I look at my overall trends? Okay, so when I say, hey, I did a really bad gallbladder surgery and it took me 30 minutes longer than I usually do, I have proof. Okay, I can pull reports from this. So much data. And as you see, we can pull videos. Everything is recorded digitally, okay? So obviously we know that the benefits of the robotics, so it was a marketing, unfortunately, but it's an expensive marketing thing. A lot of things that we talked about, visualization, movement, surgeon comfort, but also as technology advances, it should get cheaper, okay? Think about like the first, I remember, well, we can go back. Personally, when I graduated high school and went into college, I bought a compact Presario, nice desktop, 13-inch monitor, deep tube thing. The thing was $2,500. $2,500 for a computer. And now this thing, when these flat screen TVs came out in the 90s, something like this was probably $15,000. Now you can go to Walmart and get one for $300. Okay, so as technology advances, it does get cheaper. Okay, but the other thing is it's safe as we do it. A bunch of people tried to get into the market for robotics. Intuitive Surgical is the main player. There's a couple other ones you might recognize. Stryker does a lot of medical stuff, med robotics, med tech, and then there was this one that was called Verb Surgical. A lot of people have tried to replicate, never duplicate, but just replicate, the advances that Intuitive has made in robotic. This is actually a Google Ethicon fusion, but they haven't come out yet. Okay, so lots of companies have tried to do it. Medtronic, if anybody has pacers, Medtronic makes a lot of pacers. So everybody's trying to get into the robotic market. And it doesn't really work. Intuitive's been there for 25 years, but they're getting there. Okay, so where are we going in the future? Okay, so telemedicine. We've already said it would be really cool if you need it, or if you frankly don't have a surgeon that has that capability. Okay, so let's say KCH had a robot, but no surgeons to work the robot, and they had a patient with a problem that could be fixed robotically. Well, let's grab a surgeon in Cleveland or Columbus or Cincinnati or hell, LA, and have them telemed in and do the surgery remotely. That's possible. Okay. Other thing, telemedicine, we actually do this now for services that we don't have. So unfortunately, if you go to the emergency room with like a stroke, and you need a neurologist. We don't have any neurologists on staff, let alone 24/7. So what you do is you interface, basically on an iPad, you're FaceTiming a physician. Okay, that's considered telemedicine. Okay, single incision techniques. I'll show you something here in a second. So can we do the same surgeries that we have with 3 or 4 or 5 incisions with 1 incision? Okay, can we do that? No. Nanotechnology. Can we inject you with something and tell those little nanobots to go cure your atherosclerotic plaque in your descending aorta? I don't know. Maybe. Can we? We might be getting there. Nanotechnology obviously is coming a long way. Voice and hands-free control. This is where video gaming technology actually comes in. So with Kinect and everything. So AI and voice control is becoming really integrated. So as we all hear in the the news and the media about AI is actually being used in surgery a lot. There are studies going on right now. The biggest thing that I don't want during surgery is a complication. I have to make surgical decisions based on what I see in front of me. There are studies out there to say, what is the AI looking at versus what I'm looking at, and who has the better decision-making rate? Okay, just based on, obviously the AI person doesn't know how to do surgery, but they're using the AI technology to not pit, but compare AI decision-making versus my decision-making, okay? Labeled target anatomy is pretty cool. So like that green fluorescence that I gave for the gallbladder surgery, we can give you a dye, I can flash you with a special laser light, and I can have your lymph nodes light up. I can give you a dye if I'm doing a cancer operation and having just your tumor light up so I know where to cut and where not to cut. Okay, so that's kind of cool too. All right, so the one thing that we had to take a look at is what is the future? I say future of robotics, but what's the future of surgery? The way we were doing gallbladder surgery in the 50s is not the way we're doing the gallbladder surgery now. I would be dumb and ignorant to assume that the way we do gallbladder surgery in 2050 is the same as how we're doing gallbladder surgery today. We just don't know what that looks like yet, but we have to prepare for technology. So this is a scary instrument. That was a laparoscopic single site thing, but they tried to have 2 hands almost like a big tree chomper. This is what the current iteration of the robot looks like. And this basically says, okay, where have we been? These are all the same thing. So for you guys who don't know, these are SD cards for your camera, 256 megabytes, 256 gigabytes, 2 terabytes of information, all on the same damn thing. okay? This is where technology is going, and then there's where all of our iPhones are, okay? So technology is always advancing. Now, from a surgical perspective, just because it's available, then we have to go, okay, can we apply it in some fashion, okay? And then, so this one's actually a good clip if it goes up. So this is the single port, okay? I don't think we need anything. So this is the Da Vinci SP. This is one single incision with one single trocar. Goes through your belly button. There's the camera, there's the 3 arms. Okay, all wristed and articulated instruments, all moving, all through a single incision. All degrees of freedom, everything.
It's very Doc Ock.
It is, very Doc Ock. Now the cool and interesting thing is, 11 years ago, this video was made. This is real, this is here today. That's about a $3 million platform. We don't have that here. This is really good for prostatectomies, okay? This is just kind of a thought that the medical community thinks of. So in the era of healthcare reform, limited funding, obviously expense is always concerned and scrutinized. Robotics and surgery is correctly under intense scrutiny. It's really expensive, okay? Thus far, the cost-quality equation for value often has been at odds with additional investment of healthcare dollar in robotic technology. A lot of people have said, if I can do this surgery laparoscopically cheaper than robotics, why do I need to do robotic surgery? Okay, well, everybody had rotary phones. Why does everybody have a cell phone? Okay, Chevettes were great. They're not around anymore. Okay, so technology is advancing, and this is just one platform of technology. So the scrutiny was the apparent waste incurred pursuing a flight to the moon led to a giant step forward in technology that proved to be a tremendous value in other areas. It did, that was costly. Is this a paradigm for robotic surgery, thus justifying the cost, expecting benefits with experience over time? So surgeons must contribute meaningfully to the debate, helping to guide industry, government, and payers in a path that best serves the safe, efficient, value-based care of the patients. So in the end, we do want to provide good value-based care based on data, which is why everything that comes out was scrutinized, which is why laparoscopic surgery was scrutinized so heavily in the 90s. Then it became standard of care. Robotic surgery, interestingly, has been around since early 2000s. It's still being scrutinized because of the cost, okay? So that's my coolest picture, okay? So I don't know if this is ever gonna happen, but so will we ever let robots actually operate on us? So thank you.